Good morning, and welcome to the EHR panel at the SoCal HIMSS Health IT Conference. My name is Bella Zaghi, and I'm a data report system analyst at Cedars-Sinai, and I'm a committee member for the Academic Alliance Committee for SoCal HIMSS. I have the distinct pleasure to introduce and personally know the moderator for this panel. I have known this gentleman for over a year, and he has served as an inspiration and mentor for me in my life and career. Shadaab Kanwal has proved his unwavering investment to advance the health IT arena with his consistent contributions to his current and past prominent organizations like UCLA Health Sciences, United Health Group, and the Mayo Clinic. Presently, Shadaab serves as the Executive Director for Research, Health Policy, Quality and Care Delivery Excellence, and Community Benefits IT portfolio at Kaiser Permanente. At Kaiser, Shadaab orchestrates the delivery of smart technology, innovative learning systems, and integrated healthcare and analytics. He is an active member of CHIME, ACHE, and HIMSS, where he establishes and promotes Kaiser Permanente's expertise in high-performance computing and intelligence for healthcare delivery and global medical research. Without further ado, please join me to welcome Shadaab Kanwal.
Bella, very kind of you. I think you've done a great job in conducting this conference, and I really want to congratulate all of the HIMSS SoCal committee for making such a wonderful effort. So thank you so much for bringing me in. Well, folks, we are here for a very exciting session, and I have a distinct privilege to conduct this session where I have prominent panelists who are industry experts, physicians who will share their personal experiences, and then we can engage into a very interactive dialogue. I will encourage a lot of questions from you folks to the distinguished panelists so that we can really explore the myth of EHR, but which is now becoming a reality. So there is some, feedback that we received about our topic, pros and cons. Well, a lot of folks don't see it as cons, but see it as issues. So we'll probably recraft it and probably present it as issues. So, having started the panel today, I am going to have the way we're going to conduct this session is I'm going to have my prominent panelists introduce for a short while about themselves, and then at the same time what work they do in a very brief way so that we can have some background about them, and then we can have an opening presentation, a very short presentation which can trigger the conversation about electronic health records. So I will invite Dr. Charles Jaffe, who is the CEO for HL7, to start the dialogue by introducing himself. I think a lot of you already heard him on the previous panel, but for the benefit of those who are just joining now, Dr. Jaffe.
I had a problem with the microphone the last time, so. I'm a oncologist by training. I spent a better part of my career in academia and clinical research. Much of it was about connecting patient care and research data so that the reuse of data was a typical aspiration of caregivers. Now we're getting to a point where they're understanding that data reuse is really key to making healthcare quality more higher quality and more affordable care. For the last 2 decades, I've been involved exclusively in healthcare IT.
Great, thank you. From Marion, if you would don't.
Good morning. My name is Marion Jenkins. I'm from Denver, Colorado. If you're curious, it was 84 on Sunday and snowing like crazy yesterday and in the 60s today. I have a PhD in mechanical engineering from Stanford. I head up the graduate healthcare IT program at the University of Denver. But my day job is running an IT systems integration company by the name of QSE Technologies. We're based in Denver. And we work on the IT infrastructure to support EHRs and PACC systems and practice management systems all across the country. Our company's been in business for 10 years. We've done over 200 healthcare projects. We don't sell EHRs. We provide all of the infrastructure and in-office and private and hybrid cloud solutions for mostly large physician networks, practices, clinics, ambulatory surgery centers. We love to have a company like Kaiser as a customer. They're sort of the poster child for healthcare IT and automation, but we work more in the trenches where physicians live, where most patient encounters live, and which is largely still unautomated.
Thank you. Please.
Good morning, or afternoon now. My name is Neil Triester. I'm a cardiologist, but my other job is medical informatics officer for Sharp, and I work with the IPA side of Sharp Healthcare's affiliated medical groups. There are two. There's a staff model, Sharp Reese Daily, and Sharp Community Medical Group, which is the IPA model. And in that role, we are involved in deploying an implementation of Allscripts EHR across approximately 100 to 120 independent practices throughout San Diego County. So my job is actually selling an EHR to every single practice independently and implementing and hopefully gaining adoption. And my interest is in taking this implementation and turning it into the real use of information and logical decision support. And I have a lot of experience now with what doesn't work in implementations and hopefully a few nuggets about what does work.
Dr. Hara.
Hi, I'm Jimmy Hara. I'm a family physician. I'm the Residency Director Emeritus in Family Medicine at Kaiser Permanente, Los Angeles. But I was at one time what they call a designated institutional official. So I was in charge of all of the residency training programs that Kaiser Permanente has, which includes 5 family medicine residencies in Southern California. And a decade ago, basically, Health Connect went live in Southern California, Kaiser Permanente, and gradually I got involved in making sure that all the residency training programs appropriately deployed our electronic health record. And the Kaiser Permanente system, Health Connect, is a totally integrated system. So understand, the pharmacies, the laboratory, imaging, the hospital, and the clinic, they're all in the same system. And it's a national system as well. So if I want to, I can look up records, if I need to, of a patient who maybe has coverage in Hawaii, or Cleveland, or Denver, or Atlanta, Georgia, wherever Kaiser Permanente has presence. And actually, just this past month, Kaiser Permanente won the Organizational Excellence Award from HIMSS, the Davies Award, which I guess Neil didn't realize that Nick Davies was a cardiologist. And actually, if you don't know, Nick Davies was the president-elect of the American College of Physicians about 20 years ago, and he died in a plane crash before he ever served as president of the American College of Physicians. But he was, as he likes to say, he was a geek and a nerd, and he really embraced library science as well as information technology, and so the highest award that HIMSS can provide is named in his honor. In addition, actually, as it turns out, we have 36 hospitals in our system nationwide, and all 36 are level 7. And understand there are only 67, I think, 66, 67 hospitals in this country that are level 7 in terms of HIMSS. So it turns out all of our hospitals are level 7, and because we happen to be part of this totally integrated healthcare system, which parenthetically, we went live this past month with iPhone, smartphone, Android app that patients can look at their own information, and they can email their physician if they have any questions.
Thanks, Jimmy. I think it gives you a little bit of background about the diversity of the panel and the rich experience that the panel carries. I think so what the process that we're going to follow is we're going to walk through a quick presentation from Marion and basically try to address some of the really glaring questions within the EHR domain. Is it really worth all the effort? What are the tangible benefits that the physicians and the patients, as well as the rest of the clinical staff or the healthcare professional, attain from them? How to best anticipate the hurdles that come along the way, and then how to prepare for them, and what systems do need to connect. So we'll try to walk through that so that there are some tangible, takeaways for you, and that can help based upon this experience. So Marion, do you want to lead us into this presentation? You can, and I can walk it through you.
Okay, good. So yeah, just go ahead and go to the next one. I can see it from here. We've actually already talked about this, so we can just skip that slide. So I put my University of Denver credentials on the title slide because I'm using unauthorized copyrighted material, and because I'm a professor, it gives me the right to do that. So this is used without copyright. This was the state of the art of medical records back in 1970. We need to go back there. Yeah. This is the state of the art of medical records in 1970. Now we can go to the next slide. This is the state of the art of medical records in many practices today. In fact, let me just ask you, by show of hands, how many of you, when you go to your physician now, they give you a clipboard and have paper records? Okay. So the topic of our panel was EHR's pros and cons. Right now today, somewhere in Los Angeles, there's probably a convention or a conference of people that are in logistics and people from like FedEx and UPS. They're not having a discussion about automation pros and cons, how to track your package, is it a good idea or not? Or fast food, McDonald's isn't having a discussion about, should we use paperless menus and things like that. So here we are in 1/6 the economy, and we're still having discussions about that. So the one on the left, unable to decipher the doctor's handwriting, he can't tell whether the patient's been released or is deceased. And I've actually experienced the one on the right. I had some knee surgery several years ago and had to crutch through the hospital signing out in various departments. Okay, go ahead. So here's the numbers. Only about 25 to 30% of medical practices actually have a functional EHR. You see some studies that say it's 30 to 40%, but if you really look at functional ones, it's much lower. So that means that there's a very high percentage of medical practices that are still paper-based. And so this creates a tremendous digital divide. And it creates a kind of a self-fulfilling prophecy, because if you don't have the data, then the data isn't valuable and you can't get the clinical quality outcomes and reporting and registry and some of those things. Okay? So, bonus quiz. Does anybody know what this picture really is, by the way? It's the top one. It's the Klondikers trekking up to Chilcoot Pass in the late 1800s. The second definition is people lining up for their cash for clunkers, and the third one is physician practices trying to line up to get their era high-tech and meaningful use. So here's some common misconceptions. I'm having trouble reading it backwards in the mirror, so that's why I have to keep turning around. First of all, a lot of physician practices we see, and a lot of physicians and CEOs are saying it's okay to wait and see. Some of them think that hospitals are going to come to their rescue and provide services and hardware and software, and that's happening in many cases, but it's also not happening in many cases, or those services that are being provided are not what the practice wants. And if you don't want to, or you don't have any, if you don't qualify for era high-tech funds, you don't need to worry about HIPAA and some of those kinds of issues. So these are some common misconceptions. And there's some very off-putting headlines, and I'm really happy to be on a panel with physicians who are pro EHRs, because these are some of the things that physicians are hearing from their peers, and these are largely horror stories that are causing them to sit on the sidelines. First is a seminar I've seen that goes all around the country called How to Be Sued by Your EMR. and this is actually sponsored by a medical malpractice insurance company in Colorado. It drives me crazy. Now, their session is actually very good. There are ways that you can get sued by it, but it conveys the wrong information. Let's see, just one more. What you don't know about your EMR can kill you. There was an article in Healthcare IT News by a guy by the name of Gordon Moore. Does anybody know who Gordon Moore really is? One of the founders of Intel. Well, this was a physician named Gordon Moore, and he called EMRs a Ponzi scheme. So, thanks.
Well, that's great because that kind of tees up for us now. So I think it leads us into our question session, and my first question to the panelists is that a number of intangible benefits that we derive from a clinic's EHR or EMR implementation includes improved population management capabilities, e-visit capacity, pay for performance readiness, or brand recognition. These are most of the tangible benefits that you can get out of it. And then you have a local enhanced or a regional, in Kaiser's case, I would say a national recognition in that way. How do you see that your organization has taken advantage of those benefits, and or do you still are in the process of doing that? And may I field the question to Neil to start with?
Well, first I'd argue that there are benefits yet, and the reason is in part because what the clinician sees, and again we're dealing with very small practices of 1 and 2 and 3 doctors, what they see is a whole bunch of collecting of information for a year or 2 or 3 before they get any benefits. The benefits are not initial, and so there's an incredible investment of time and faith. It is a leap of faith. The other issue is that from the organizational perspective, and we have 120,000 capitated lives, our physicians care for probably another 250,000 lives, so we have a very large percentage, relatively speaking, of healthcare in San Diego County. And we don't have the critical mass yet on our EHR to actually use the data in a meaningful way yet either. So we're looking still at claims data and other very archaic ways. So we strongly believe that the promise is there, but the reality is we have not realized that dream yet, and I think we're a year or 2 away. We're just starting to give some of those initial practices meaningful data back. But again, it's after a fair amount of pain that they've had to endure to collect that information.
Jimmy, one of the feedbacks that normally from an implementation perspective comes is that physicians are needing to type in too much information with the very least temporary decrease in their office visit documentation. How has Kaiser been able to overcome that kind of scenarios?
Yeah, fortunately, the Epic product, the Health Connect, is a very user-friendly system, especially for physicians. We can make a dot phrase for paragraphs that we ordinarily used to write, and make a dot phrase, heart, dot heart, and then up comes this huge paragraph that we can then edit. So very quickly we can process a note. And parenthetically, in terms of population care management, I just want to also mention we have a system. It's a national system. It's called POINT, Permanente Online Interactive Networking Tool, is what POINT stands for. But what it is, it's a registry of diabetics, patients with cardiovascular disease, patients with asthma, patients with hyperlipidemia, and basically, and every patient has a primary care physician. So I get data on my patients who have cardiovascular disease and how they're doing in terms of whether they're on aspirin, lisinopril, a beta blocker, if they've had a heart attack. Basic clinical information I get, or if they're asthmatic. Theoretically, you want them to be on what we call controller medications, inhalers, instead of rescue medications. And there's a ratio of, we don't want them to be refilling the rescue medications all the time. We want them to be on their controller medication. So we look to see the ratio of how often they're filling the different prescriptions. The registry is unique. Understand, I've also volunteered at Venice Family Clinic for 40 years, and I just stepped down as their chair of the board of directors, so I'm familiar with what Marion was sharing, this whole digital divide issue where we're, this is a community health center that is still trying to decide which product, and I think they're going with next gen. But anyway, with Point, the registry, rather than being made by physicians contributing names of patients with diabetes, heart disease, and what have you, the pharmacy provides the names of anyone ever prescribed a medication like metformin, which is used for diabetes, but it's also used for like infertility and things like that. They will provide, and they'll automatically get put onto our diabetes registry. Anytime I have ordered a test called a hemoglobin A1C, which is for the control of diabetes, they automatically go onto their diabetes registry, even if I ordered the test with this individual only to prove, no way do you have diabetes. And it's perfectly normal. But they're still entered into the diabetic registry. And so basically, whereas in every other registry I'm aware of, it's the physicians who enter all the names, in this situation, it's the pharmacy, it's the lab, it's imaging that enter all the names, and it's the doctor's role to vet the list. We just say, oh no, this person doesn't have asthma, oh no, this person doesn't have heart disease, or what have you. And then we wind up with a list, and then that list tells us how we're doing. Do we have the cholesterol in control? Do we have, and what have you? And all of that information is also available to the patient. And the patient is told, oh, by the way, your cholesterol is this, that, and your HDL and LDL cholesterols were this, that, and the other. And parenthetically, if you have diabetes, we would recommend that your LDL be at this level. If you have if you have no history of any heart or diabetic disease, then it's okay to have an LDL at that level. And they're provided that information. And then, and even if it's like 1 point higher than it should be, automatically I can expect an email saying, doctor, what are we going to do about the fact that, my cholesterol is a little high?
I'm just going to shift a bit of the gears from the physician side of it to the technology part of it also. And Charles, you are with the organization HL7, which created the functional model for one of the functional model for the electronic health record. And so how do you, please describe how it seeks to create a flexible, cost-effective approach, standards and guidelines, methodologies, which kind of facilitates the process of interoperability within the electronic health record?
You have an hour?
No.
No. Okay. The electronic health record functional model is an ISO standard about 10 years old. It has been updated multiple times since then. It serves as a foundation by which other specifications, we call them profiles, restrain the larger model. So there are profiles for pediatrics. It's now AHRQ standard. There are profiles for cardiology. There are profiles for family health and so forth. I think the big leap, which was announced at HIMSS this year, was that HL7 was making its functional models, its profiles, its domain analyses free on the HL7 website. And to date, we've had about 2,000 downloads of those profiles and those models. The vision is to have a single architectural framework around which an electronic health record can be built. If you look at the infrastructure by which some of the vendors have created their applications, they've not grown organically from a single vision. They've bought a company that does lab implementation, or they've acquired a vendor that does PACS. And there are implementers who exist solely so that the ambulatory system can talk to the inpatient system, or radiology can communicate with ADT. And so the ones who will have success in the future and will not be left by the roadside are the ones that have been developed around an integrated architectural framework that translates into some degree of interoperability. The second issue is the V2 messages that I alluded to. When HL7 came into being about 25 years ago or so, it made a promise to be backwardly compatible and to enable customization. It was that latter promise that created the nightmare of incompatibility and lack of interoperability among systems. So the two most connected hospitals in Manhattan a couple years ago couldn't share electronic health records. The best way to get data between them, whether it was ambulatory or inpatient, was to print it out and put it in a taxi and drive it across Manhattan. There are solutions now based on the HL7 information model. There are senior thought leaders in the United States who say that that model is too hard and too complicated and the concepts are too obtuse. But in fact, one of the most popular technologies now supported by HL7 is called Clinical Document Architecture, or CDA. And is this CDA, which is really the foundation of Meaningful Use 2, supports a host of different capabilities, including quality measures and decision support. But even more importantly, CDA is the technical model for sharing information in Europe. The EPSIS project connects 24 countries in 27 languages, and the HL7 CDA provides a carrier technology for clinical summaries and electronic prescriptions. So it is not what is unique and customizable that makes the data valuable, but what we have in common and what we can share between healthcare systems. Anybody been to Australia? So the last time the U.S. got it really right was the Continental Railroad. We said we only could use one gauge of track, and there they met somewhere in Utah, and lo and behold, the trains ran from one system to the other. In Australia, there are 3 gauges of track, and for them, interoperability is lifting up the cars and changing the wheels. And so if we're not careful when we try to develop a national network and share ambulatory EHRs, we're going to have to lift up the cars and put in the wheels. So adopting a set of specifications or an architecture that can ensure interoperability is really the aspiration of HL7.
Marion, do you have a comment?
Yeah, just to tag on to that, as I mentioned earlier, we do not sell or promote or represent any EHRs, and I want to make a statement. I'm pretty sure it's correct, but since with your credentials, I'd like to check this out. We sit in on many software demos, and hopefully there's no software salespeople in the room that I'm going to step on toes. But a physician will ask, if I buy your system, will it talk to my oximeter, to my my infusion pump, to my PACC system? And the answer comes back, our system is HL7, it's .NET, it's CCHIT, it's SQL Server, and it's web-based. The physician hears, yes. And the right answer, and this is, I have a slide, I do some work on some other stuff on interoperability, and HL7 not equals interoperability. HL7 is like he and I both speak English, but that's kind of the end of it. It just means that the syntax is the same. Patient name is the same. If one system is going to be first name, last name, then all the systems will be first name, last name. They're not going to jumble them up and do things like that. It means it's possible to make them talk to each other. It doesn't mean that it's automatic. But many of the systems are sold, unfortunately, and bought, unfortunately, with that in mind. And so one of the areas of disappointment that people have is they say, well, I thought you said this was interoperable. And they said, no, I didn't really say that. I just said it was HL7, .NET, SQL Server, and CCHIT.
So give me 1 second, and I will create. So the EHR functionality list organizes these elements, whether it be the functionality list that is coming from BHC, CCHIT, HL7, Physicians Foundation. There are different, functionality list. And they have contributed in the evolution of this ambulatory health record, which was in 1991 described by the Institute of Medicine. How would physicians who have adopted software before the release of these lists may review them to solidify this choice of an EMR? I mean, I don't know if the physicians have gone through the process of adoption, or do you want to comment on that?
There are a host of websites. The American College of Physicians and other professional societies now supports the American EHR project. They go into exquisite detail about issues such as interoperability. Let me say that I agree with Marion's statement. So it.
I've been saying it.
Yeah, well,
It's true.
yeah, it's true. The other website that I referenced, the Healthcare IT Exchange, is peer-reviewed. So clinicians, nurses, physicians, pharmacists, etc., review the implementations. Now, not all 1,700 products available or recognized in the various registries, but a good many of the leading ones. And so you can have objective assessment about compatibility, implementation, and so forth. Let me one last comment about interoperability with devices. The device manufacturers haven't agreed on interoperability standards. As a matter of fact, I was at a meeting at the FDA last week, and I assure you that most pulse oximeters, pumps, ventilators have no direct connectivity specifications to health information systems. In fact, if the nurse doesn't set the time on an IV pump, when it goes on and off is a total mystery to anyone but the person whose infusion is being completed. You could abstract the system time right off of the HIS software, but in fact the devices do not do that. So interoperability isn't the fault of the standards makers, it's a fault of the people who have no business case for implementing interoperability. So it's up to you, the people who make the critical decisions and inherently write the checks to drive those sort of interoperability requirements. Right now, we simply have a complacent set of buyers.
Jimmy, you had a comment?
Yeah, actually, a comment I was going to make a little bit earlier is Kaiser Permanente is part of what's called the Care Connectivity Consortium. Intermountain Healthcare in Utah, Mayo Clinic, Group Health Cooperative, and Geisinger in Philadelphia, and Kaiser Permanente. We are now able, at least at certain levels, to get records, critical information from any of those systems. And similarly in San Diego, actually, the VA in San Diego and Kaiser Permanente in San Diego basically can now communicate with each other. So I think little by little we're getting there.
Interesting thing is on the Care Connectivity Consortium perspective is that during the pilot we find out that 9,000 of Mayo patients are in Kaiser system, and that was really an eye opener that those patients basically Kaiser is not in the area of competing area with Mayo, but yet those patients were found into it.
I have one other little bit of data, is that sharing patient records really is predicated on identifying the patient correctly. If I'm not mistaken, Kaiser Permanente, Southern California, has 10,000 Maria Gonzalez. It makes patient identification with probabilistic matching a difficult chore at best, and without a uniform patient identifier, a critical issue as we begin to share data nationally. One of the key goals of this care consortium, because I sit on the panel as well, is being able to better identify patients. So it's not simply that we can't share the data, it's that we can't share the data accurately.
Just to change the pace on coming from the physician's perspective again on this one, one of the particularly gratifying benefits of EHR deployment or an implementation is the capacity to have an open access, system where you are able to have an appointment capacity building, and you can enable the patients that call you at the last moment and yet be able to accommodate that. From the physician side, any of you want to see that? Have you started seeing the benefits, or still in the process of trying to realize the benefits?
Yeah, well, in KP, I've certainly enjoyed the benefit, at least for the last 5 to 6 years, for sure. The other thing I just want to mention in terms of HIPAA and confidentiality and what have you, we have what we call secure messaging, where you can email your patient, and only they have access to the email and what have you, and they have access to their own information. Similarly, we protect the patients even when they wind up in the hospital. And the best example I can give you of that is Octomom, when she delivered at Bellflower Kaiser, now Downey Kaiser, I guess it's called. But anyway, when she delivered, the following morning, 17 employees were fired because they looked at her record and had no business looking at it. After that, we implemented something called Break the Glass, where if it's a celebrity or if it's a public servant of some type, someone who has notoriety for whatever reason, if a physician or anyone else for that matter wants to look at a record, it will give you a chance not to look at it. It will say, do you want to break the glass? And if you say yes, you have to also explain why you need to break the glass. And it might be because you're taking care of the patient, and that's fine. But anyway, there's a record of when you looked at that record, exactly what time, and for what reason you claimed. And that's, so Kaiser Permanente at this point, we are, the HIPAA compliance is not a problem, as opposed to, I guess when you were at UCLA, Britney Spears, if you recall, it took about 2 years for some of the people to get reprimanded.
Why do you think I changed the organization? No, I'm just kidding. Well, one of the some of the problems that, how many in this audience is a clinician, or they interact directly with the patient care? So very few of them, and interestingly, this is the audience that's the most, that's the most beneficiary of this electronic health record. So a lot of the feedback that comes from an electronic health record implementation comes to the point that it takes excessive time, and then the effort that is required to input into the computer is really, really incredible. So which kind of impedes the productivity, but yet at the same time, they have to kind of continuously perform their quotes unquote day jobs, which means that they have to take care of the patients. And I think some of it comes from our physicians, also, where how do you see the electronic health record benefiting or not benefiting in that environment? Neil, do you have a comment?
I have many comments.
Okay.
my bias certainly is, from my perspective, it appears that the EHR was developed, as someone said earlier this morning, to mimic a paper record for the purposes of billing. And that's really not what the clinician wants. What the clinician wants is simply for the EHR to know who I am, who the patient is, and when I walk in the door, what information I need, and how do I best organize and review that information and then act on it in a way that is best serves the health of the individual. And we are woefully a long ways away from that goal, unfortunately. And so, it's the way EHRs currently work, at least the ones that I have had the experience of using and observing, is that there's it's like Maslow's hierarchy of innovation being somewhere so many stages away from where we need to be. Just getting through the day, getting through the appointment, being able to do what you used to do in an electronic world is kind of job one. And innovation and quality and understanding the information and looking at your practice patterns and looking at your population is so far removed because of the exigencies of what you have to do to get through the visit. And I think that's a shame, and I think it's in part because the way they were designed, and in part because the way we implement them and address how they're to be used.
So before, Marion, you make the comment, I want to tee it up for you. So, suggestion is that the implementation problems tend to fall into predictable categories, which basically are infrastructure, which is that inconsistent network availability. You can't talk to that, to the devices, or you input the data, your thin or thick line does not respond, thick lines don't respond to you immediately. Then there is an organizational culture. So that basically means that there is a resistance to change within which can be accommodated through the training, which is basically that you have the quality and the attendance of the training in factor. Marion, how do you see that technology becoming a barrier, but at the same time, facilitating this process of successful adaptation and implementations?
So I'll use an example. How many of you are on LinkedIn? How many of you are participating in any of the HIMSS discussion groups on LinkedIn? Have any of you seen the discussion called the top 10 reasons why EMR projects are failing? Are you on that? It started last year. There are like 4,000 entries now, so there's obviously more than 10 reasons. And it's devolved into a shouting match between resistant positional providers who say this hurts my productivity, or it hurts, I'm not going to be a typist. And then on the other side, Kool-Aid selling vendors who say it's all perfect, it's HL7, it's .NET, use it, what's wrong with you? And it's a noise canceling thing. I think we need to, so I think it'd be really valuable if everybody, both the kind of the vendor and the pro technology people, which really is kind of what HIMSS is, if we maybe chilled a little bit, and providers also chilled a little bit, and we collaborated a little better, because right now, even though we've been doing this for 20, 30, 40 years in terms of some kind of health IT, the very first cars didn't go even faster than you could do a brisk walk. There were no gas stations, there were no roads, and if somebody were to look at that and say, this is an absurd technology, I can walk faster than this, my horse is more reliable, cars break down, everything else. That's kind of where we're at. Even now today in 2012, we're still at a stage where we still have a disconnect between processes and technology and the human interface and typing, and at the same time, many physicians are getting older and the devices are getting smaller and my eyesight's getting worse. And so you just have these really functional issues that are, and the vendors can blame it on the doctors and the doctors can blame it on the vendors, but really we all just need to kind of get along and move past that and somehow get to the point where people are looking back like Kaiser does now. And Kaiser looks back, and I know lots of Kaiser doctors, and I say, would you ever go back to paper? And I would never do it. And so we've got to get past that hump.
Yes.
So I can speak as both a clinician and a technologist and say that policy trumps technology every time. The issues that delay or impede rapid advancement are related to human factors and not the ability of engineers to write code. Certainly proven by the remarkable objective data at Kaiser, which demonstrates far superior outcomes in a host of measurable factors based on the senior leadership's insistence that these goals would be achieved through improvement in these important characteristics of functionality and improving quality. And I can say this, I've never been a Kaiser patient, I've never worked in Kaiser. I am an admirer of their achievements that have been based on the willingness of the leadership to focus on the goal of getting better quality care for patients.
So just to kind of react to that, I think and I've been only with Kaiser for 7 months, but from an experience perspective, it's a phenomenal experience. And in just a recent conference, I was sitting with Christopher Shute from the Mayo Clinic and Blackwood Middleton from the Howard, and we were chatting about the experience. And I was totally Mayo spoiled. When I used to work for Mayo Clinic, the integrated delivery care model was absolutely phenomenal. But when I came to Kaiser, I felt very much the same, not the boutique sense of it, but very much the same, and specifically the use of technology. So Jimmy, my question to you is, the critical success factors that made it possible for Kaiser included some of the things where they built clinician trust, they built team building, they had a level of tolerance built into it, and then resiliency, and of course, at the end of it, accountability. How do you see as a clinician, feeling, about all of these things which are very, vague? And, yes, Kaiser had a journey to get the EHRs implemented, but at the same time, what were you learning in that process? And that would be my last question, and then I'll open up for the audience to have their questions.
Well, in Kaiser Permanente, actually, one other thing that we try to do is we try to practice evidence-based medicine. We don't just base our practice on what the experts say probably should happen, but rather what does the evidence prove needs to be done. And David Eddy, who's an MD, PhD, he has a PhD in mathematics, is the father of what we call evidence-based medicine. And he basically created what are called clinical guidelines for care in Kaiser Permanente in terms of what we do for different diseases and what have you. And a lot of those guidelines are embedded in our records. So as we're saying, I'm going to order this and the other, the flash. Do you know that studies, and it gives links to studies if you want, show that patients on this medication should never get a dose higher than whatever. And so for being a Kaiser Permanente physician, it's been easy for the physicians to adopt the system because, we know that we're practicing the highest level quality of care, and that, as has already been alluded to, George Halverson and Ray Baxter, people like that, the upper echelons of our leadership, they're the ones who are saying this is what we need to do. And then, we also had Don Berwick doing a lot of consultative work for us, and unfortunately he never made it to head CMS. But basically, a lot of what we have in our record is based upon what Medicare, Medicaid recommend as well. And the other thing is in terms of billing for what we see, ICD-9, ICD-10, we put in a diagnosis. It automatically gives us what the ICD-9 and soon to be ICD-10 code is. So the physician doesn't need to do that. The physician just enters an appropriate diagnosis, and then we get the coding, and so consequently we ultimately get the appropriate billing.
Neil, reaction?
Yes. I am in awe of what Kaiser has accomplished. And I trained with Kaiser before the EHR and worked there for a few years before the EHR. And I'm sorry about that because I wish I had been there for that part of that journey. But you know, over 50% of the healthcare in this country is delivered by physician groups of one or two, without the resources that Kaiser has. And I just am not impressed with what most of the vendor world is bringing to those physicians in practices of one and two. And the thought that they can accomplish what Kaiser has accomplished is unrealistic as the systems exist now. And perhaps as part of the interoperability and health information exchange and other things will be some of the guidelines and some of the decision support that currently doesn't exist in the systems. And they didn't exist for Kaiser when Kaiser bought the system. They developed it and built it.
Granted, it was $4.4 billion. So the tag is not that small. Questions from the audience?
Okay, we were talking about mobile devices and emails flying back and forth from doctors to patients and patients back to doctors. What is happening with these emails? Are they being captured somehow and attached to the patient's record? Because otherwise, you may have all of a sudden the doctor is in updating his orders, you might have a medicine go out, et cetera, and there's no backup for what happened. It might have been a test of the heartbeat while they were doing some kind of treadmill thing or something else that they got all excited and they sent to the doctor. But if it's not captured, is it going into a doctor's private email
messages
or a server that the doctors are using at their facility, so it is being captured somewhere and then maybe put into the record?
Well,
These aren't freestanding emails from a ISP vendor. These are communications within the framework of the health information system. So it's not that they are tethered, they're embedded within it.
Okay. But I mean, a patient could, from their own private ISP vendor, send a doctor an email.
To what address? That's all. Good.
Yeah. I was just asking, is it being captured and pulled into the patient's record?
So the process of sending and receiving is an encrypted process, within the information system environment within Kaiser. So that's the residency is still there, within the physician email. So the physician even cannot get, access to his own system where they have not employed the two-factor authentication, or rather three-factor authentication in some cases.
You can.
Can you pass on the mic so that we can hear, please?
For the email.
Okay, so I'll repeat the question for everybody's benefit. So in general, apart from Kaiser, is there a mechanism in place for patients to engage with the physician in email communication? I think not many organizations have basically adopted those engagement models. These are the models of the future. So anybody wants to comment on that?
One of the things that we see, because we deal a lot with HIPAA security and trying to protect people from themselves, is we're having to explain to doctors why having an AOL email address or Hotmail is a bad idea for them, and they many times don't get it. Can I just say one thing about the cost issue? Because many providers say, I'm a small provider, I'm 1 to 2 docs, I can't afford it. If you take the cost of a paper record, when you take the paper, the file, the faxes, the paper, toner, storage, pulling the record, losing the record at least once during the lifetime of the patient, saving the patient record for 7 or 10 years, a paper record costs $50 to $80. So if you're a small practice with 1,000 patients, that's $50,000. I think there's an incentive there to invest in something other than paper.
Yeah, I would just speak to a slightly different issue related to that. I mean, I think most EHRs now can have partnerships with portals which provide that secure link. But the second question comes up is when the physician and the patient are then interacting face-to-face, is that information really easily retrieved? And does the physician walk through the door and the system tell them what's happened in the last 2 or 3 months for this patient that you might want to have in the front of your mind as you go into this interaction? And I think that answer is very hit and miss. It probably doesn't exist.
So
Please introduce yourself.
I
also.
am Leslie Barden, and I am a graduate student in health informatics. Thinking about the question of the identity and 50,000 Mary, whatever, where are we in terms of biomarkers and other ways of truly identifying patients and, retinal scans, that kind of thing, to ensure that we're not treating the wrong person? And then I had a second question, and that has to do with the sharing of information with the current kind of emphasis on consumers' access to their healthcare data, and we're using these data to drive clinical processes. How much of that is available to me so that I'm aware of how my data is being used and actually drives healthcare processes? So I have those two questions. Thank you.
Who wants to take it?
Well, I think the question of identifying patients across multiple systems and even within an office is a huge one, and it's the only realm that I feel less comfortable talking about than EHR is politics. And I think a lot of that exists in the realm of politics. A national identifier number really needs to exist, and that, as I recall, was part of the HIPAA legislation that was struck or taken out of that legislation when it went through the legislative process. So I don't know that we have the political will as a country to actually institute that, but it would certainly make sense.
Got it.
I can comment on that very quickly. So the far right and the far left will block any attempts at a government-mandated national identifier, as bizarre as that seems. But there is now underway an initiative to have an opt-in. So although it circumvents the realities of an identifier, if you opt into a national plan, you can choose for yourself a number. So the vast majority of people will acquiesce if they're aware of it. Most people are concerned about privacy until they need the information shared, and then they're appalled by the fact that we can't do it. I think there is a trend to developing it, and I know the CARE consortium is making an effort to encourage that, but I think we're a long way off because of the state of politics of the country.
Does it answer your question?
Yes, partially. And then the other question about availability of my data to me as a consumer, and it kind of ties in with this patient identifier number, because we're moving to a record that is going to be a lifetime, history of my health and medical care. And the more and more and more data that we collect, it seems that then it muddies the water, if you will, for, in terms of outcomes. And I think it's that kind of information has been referred to as loosey information, that really the more and more and more we collect, the less really valuable it is in the sense of driving outcomes.
I see two hands in that corner, please.
I have a quick answer to your second question. HIPAA security requires you to deliver an electronic version of the patient record upon request by the patient. So that's already in place.
The question is, what does version mean and what does upon request mean? So that'll be implemented at a state level, not at a federal level.
My name is Ali Karimi. I do have some answer for your, as far as the patient records. If the patients gets their information, that's on their discretions. If the patient send the information to anywhere else, this is according to the NIST, National Institute of Technology in Gaithersburg, which they designed a HIPAA compliant. If I'm a patient and I have my information, I lose it, that's my responsibility. Even though between the physician and different organizations, there are securities involved with it, but if it comes into my laptop and I lose my laptop, it is not nobody else's responsibility. It is the patient's responsibility. Just I want to add that because I'm a member of the NEST. That's what the NEST is going towards, that direction.
Right, thank you.
I just wanted to clarify about
Introduce, please.
Yeah, Ray Aller from USC.
I know you, but the rest of everybody does not.
All right, thank you. I thought I could slip under the, no. It's about identification, though, is the question, and the biometric identification. Use of biometrics does not require any kind of national identifier. It just simply requires that we use a biometric that then can be reproduced from one place to the other, something like the palm vein or something. And I'm really appalled that we are continuing to care for patients in this country without really knowing who it is we're caring for. And a patient comes in and says, I'm John Jones, and we give them care. The fact that they're using their brother's insurance card because they don't have insurance, we don't detect that until they have perhaps they have a transfusion reaction or something terribly adverse. I really think we ought to be encouraging the use of biometrics in every one of our healthcare institutions as they come to the door to say, who are they? And we don't have to know even what name that corresponds with, just know that that's the same biometric as you saw last time, so therefore, presumably the blood type and some other things will be the same. So, any comments from the panel?
I categorically agree with you on that. I think the possibilities of utilization of technologies for biomarkers and within the genome space, we have made incredible, successes in that. Granted that not all of that genome, even though at Kaiser we have 150,000 specimens of that genome process, captured. We still are in the process of developing that, so it's evolutionary. Apart from the policy decisioning that goes along with that, the technology capabilities are also evolving and emerging, and how does that factor back into the EHR environment? I think that's still a question for our vendor community to address also. Ray, you have a response back, I guess. Sure. I think the integration of those technologies is another complexity from technologies that comes into play. You have a response, Marion?
Well, just the Maria Gonzalez story. There's 10,000 Maria Gonzalez's perhaps in Kaiser's system, but what if one of them says, actually my name is Maria Luisa Gonzalez, and that's in the PACC system, or that's at the pharmacy, or that's at an outside clinic? Who gets to say that should be changed in the system? Who actually owns the data? In terms of interoperability and the master patient record and so on, because somebody can make a change and then it can propagate through the system and it might be incorrect. Where's the error checking? So there's a whole host of issues around not just identifying the patient, but which system controls when you have multiple systems.
And I agree with you, Marion and Ray. Although the policy decisions can really create meaningful incentives, so that's why I think for physicians to produce that data, for capturing that high quality data, which basically end up improving the quality of care. Anybody else has one? Okay, please.
Yeah, I have a question for the panel regarding small physicians' offices, and where do you see this, well, my name is Jan French, and I actually sell software. And I'm finding that it is the small physicians' offices that we're running into just huge, big roadblocks. So my question is, unlike Kaiser Permanente, where there is leadership, there is a system, controls and policies are put together, what happens to the small physician out there? How does this whole progression to electronic health records, it's like herding cats. How do you get them involved where they can really, truly understand the benefit of having a system?
Charles, you have a response?
Yeah. A high percentage of those physicians have some board certification. So boards will require electronic health records as part of the recertification process. But in Massachusetts, for example, if you want a license, you're going to have an electronic medical record. So while you can practice without board certification, you can't practice without a license. So unfortunately, the impetus will be the stick and not the carrot.
One last question in that corner, and then we can.
Hi, my name is Gina Hall. I'm a high-tech student right now. I have a question regarding, let's say if I'm a former Kaiser patient, and now I'm no longer a Kaiser patient, and I have an emergency, I go down to San Diego, and I end up in SHARP, and are they able to pull my PHR, or is that system going to talk to each other, or is that insurance issues, or you know?
If you are coming up at a Kaiser facility, the Health Connect, which is the Kaiser brand of Epic software, basically enables the physicians or the clinicians to pull the data that you have experienced in Southern California or Northern California or across Kaiser in Mid-Atlantic region or Ohio, or Hawaii.
So even if I'm a former patient with insurance with Kaiser at one point, and then now I'm no longer have insurance with anybody, and is any agency like a SHARP, let's say if I end up having an emergency in San Diego,
so Kaiser has got multiple businesses, which basically means that they have an insurance business, they have a hospital business. Having Kaiser insurance does not make it possible. However, if you're a Kaiser Foundation employee, then you are a patient, which basically means that you have been seen at a Kaiser facility. That definitely enables it.
If she goes to another company.
She's outside now. She's outside Kaiser.
Okay, that's
not aware
another.
that they can. We could wheel in a computer, and you could log into your account and access your own information. That would be about that.
Right, and I think that takes us into the next conversations that we will hear in the next sessions about how the health information networks are evolving, and what's the evolution from the RIOs to the HIMSS, and now how the exchange of the health information exchange is taking place. So I'm sorry, we are running out of time, and I don't want to keep you away from your lunch hour. We'll be serving lunch outside. We thank you so much for your participation, and I appreciate the panel's active participation in it. Thank you very much with a round of applause.
Just wanted to make an announcement. Everyone, you can